Hello, my name is Harry Ingleby. I'm a certified medical physicist providing services in diagnostic imaging across Manitoba. And I'm here to talk to you today about a change in the practice of patient shielding for all shared health facilities across Manitoba. So, what is actually happening? In future, gonadal and fetal shielding for patients will no longer be routinely used for any diagnostic imaging exam using X-rays. So this will include radiography, fluoroscopy, computed tomography, etc. Shielding will still be available in diagnostic imaging departments and will be available for use if requested by the patient or caregiver. It should be noted that this should only occur in extraordinary circumstances, such as when imaging might be refused by the patient if shielding isn't used. Prior to this occurring, there should be a clear explanation to the patient that shielding does not in fact provide any significant benefit, and the technologist should use their best judgment as to whether shielding can be used without compromising the exam. So why is this change happening now? Well, scientific knowledge has evolved significantly over the past 70 years. Professional bodies have released several position statements in the past few years advocating this discontinuation of routine shielding practice. In Canada, these organizations have included CAR, the Canadian Association of Radiologists, CAMRT, the Canadian Association of Medical Radiation Technologists, COMP, Canadian Organization of Medical Physicists, and we've also had significant input from international bodies such as the American Association of Physicists in Medicine, AAPM. There is thus a global consensus that this change in practice is evidence-based. So why did shielding come into use historically? Well, it was first adopted in the 1950s. At that time, there was significant concern about potential radiation interactions with the human body, and this mostly arose from the after effects the atomic bombings of Hiroshima and Nagasaki in 1945. This concern about radiation included the notion that if the gonads were irradiated, heritable genetic effects could be passed on to further generations. Also at this time, there were relatively high doses of radiation being used for common diagnostic X-ray exams. And we have to bear in mind that in the 50s, X-rays were captured using film but were not yet done using intensifying screens. So in 1951, shielding of patients was considered essential. Now, 70 years later, we have seen that there's been no evidence of heritable genetic effects in humans, even 3 to 4 generations after the atomic bombings. The doses used in medical imaging are lower by up to 95% due to significant advances in medical imaging technology. The evidence also shows that shielding does not actually provide significant benefits in terms of protecting the patient and may in fact compromise an exam. We recognize that this is a huge change in practice. Your training as a medical radiation technologist is to do things exactly the same way every time, taking into account the wide variation in patient body habitus and anatomy. So consistency in your practice is key to obtain the best possible diagnostic information. Some of you have in fact been placing shields on patients for more than 30 years. We recognize that this is a major change, and we are committed to providing you the best support possible in implementing this change. So getting into specifics, gonadal shielding, we have found, as I already stated, that heritable effects are not a concern. The gonads are also much less sensitive to radiation than originally thought, and this is reflected in the reduction in the tissue weighting factors used to calculate effective dose. The tissue weighting factor for gonads in 1977 was 0.25, whereas today it is 0.08, a significant reduction. There is also significant anatomical variability in the location of the ovaries that makes placing shields accurately very difficult. And finally, shielding may in fact compromise imaging if anatomy is obscured. This does not reflect technologist error, but just the variability inherent in anatomy between patients. So looking at all of those concerns, we can conclude that based on the evidence, shielding is not providing significant benefits for the gonads. We have a similar situation with fetal shielding. Fetal doses from almost all X-ray imaging procedures, including CT, are well below threshold levels that would result in fetal harm. We typically use a threshold of 100 milligray to indicate the point where radiation may result in significant potential for risk to the fetus. If you look at doses for common X-ray procedures, we see something like an abdomen pelvic CT results in a fetal dose of roughly 25 milligray, far below this threshold. Again, the presence of shields may compromise imaging due to obscured anatomy and also potential interference with tube current modulation systems in CT. So we again conclude that the benefit from fetal shielding is not sufficient to result in significant safety improvements for the patient. We next need to talk about shielding outside the primary beam. And by the primary beam, I mean the collimated beam of X-rays, so the entire X-ray field. In this situation, out-of-beam shielding is most effective when it is right at the edge of the X-ray field, so the edge of the shield is lined up exactly with the edge of the X-ray field. In this circumstance, any movement of the shield may compromise imaging, as if the patient moves, the shield may be shifted and start to encroach on the X-ray field, interfering with the function of the automatic exposure control system, or perhaps obscuring anatomy. We also have to recognize that almost all of the dose to sensitive organs outside of that collimated beam comes from internal scatter. And in this situation, shielding provides very little benefit. There are, in fact, many better ways to reduce patient dose than using patient shielding. First off, every exam should be using optimized technique. This includes things like having dedicated pediatric protocols so that children are not being imaged with adult protocols, the use of automatic exposure control to use just enough dose to obtain a diagnostic image, and things like monitoring your exposure index to ensure that you are within the acceptable range for producing a diagnostic image with minimum dose. We can also do things like adjusting positioning to minimize dose to sensitive tissues, such as doing a PA view instead of an AP view for spine and chest for young women to reduce dose to breast tissue. Finally, we of course want to collimate as much as possible to minimize radiation dose to organs outside the area of interest. The question may arise, should we in fact use shielding to help patients feel safer? The answer to that question is no, we should not be using shielding solely for psychological benefit. Our clinical practice should be based on the best scientific evidence available. We need to explain to patients that the benefits of shielding are in fact negligible and that they are not deriving any significant safety improvement from the use of shielding. In fact, the CA-MRT Code of Ethics states clearly that MRTs continually improve their practice to ensure the best possible patient care by committing to the principles of evidence-based and reflective practice. This change in shielding practice is evidence-based, and we need to communicate that to patients and caregivers. Another question that may come up is, what about Safety Code 35? Because clearly Safety Code 35 advocates for the use of shielding. Safety Code 35 is an excellent document. However, we do need to bear in mind that it came out in 2008. And of course, being a government publication, it was developed over several years based on the best evidence available at that time. So most of this research and data came from the 1990s and even earlier. For example, in the section discussing patient dose, it cites ICRP report number 60, and that document was produced in 1990, so in fact was based on data collected in the 1980s. So here we are, almost 40 years later, and our knowledge of patient doses and radiation effects has changed significantly since then. So to sum up, Safety Code 35 has a lot of great information, but is not current on some topics, and in this case is not current on the best evidence regarding patient shielding. Will you continue to wear your lead apron in your practice? Yes, you will. When patients are being irradiated for a diagnostic imaging exam, they are receiving a benefit from their exposure. And the physician who has ordered the exam has carefully weighed the benefit versus the very small risk from the radiation when they order the exam. You, as staff, do not receive any benefit from your radiation exposure. Therefore, we do not have a benefit-risk conversation around that. The goal, in fact, is to reduce your radiation exposure and eliminate any radiation exposure where possible. We also need to bear in mind that you as staff are exposed over your entire working career, whereas patients are going to be exposed a limited number of times, even if they have a significant amount of imaging. So yes, you will continue to wear your lead apron in any exposure situations when you're in the room. What about other people in the room, such as parents or caregivers who may be in the room to help stabilize a young patient during imaging? They will also continue to wear lead aprons. Anyone other than the patient should be shielded because they are not receiving any benefit from that radiation exposure. And of course, we need to bear in mind that only essential people should be in the room during the exposure. Everyone else should be outside the room or in the control room. So, in summary, routine usage of gonadal and fetal shielding for patients will be discontinued as of October 4th, 2021. Shields will remain available in DI departments, however, across all shared health facilities, and must still be available for use if requested by the parent or caregiver. However, the technologist is responsible for clearly explaining to the patient that shielding provides no significant benefit. If a patient or caregiver is insistent that shielding be used and that the exam cannot proceed without the use of shielding, the technologist should use their best judgment to decide whether shielding can in fact be used without compromising the diagnostic intent of the exam. How will shared health support us in this change? We expect that there will be many questions from patients, parents, caregivers, and the public about this practice change, given that it has been in place for many years. Shared Health has created a publicly accessible website that will provide answers to frequently asked questions and give a list of resources that you can consult further. There will also be pamphlets and posters made available to assist in communicating with patients, parents, and caregivers in the waiting room, and these should answer many of their questions and assist in these challenging conversations. Where can you go to learn more? As I mentioned, this website has been created and will be posted under the Diagnostic Services section of the Shared Health website. There will also be some live online information sessions scheduled in mid-September, and you will be notified of how to participate in those sessions if you have further questions after consulting the website. Thank you very much for your attention to this presentation. Shared Health recognizes that this will be a very challenging transition for many people, and we are committed to supporting you with the best possible information.